Welcome to the third part of Principles of Biomarker Testing. In this video, I'll be talking about molecular heterogeneity, not only between patients, but also within patients and how that impacts therapeutic choices, and also address the concern of biomarker assay performance as it pertains to PD-L1 or HER2, and go into some discussion about that to show the reliability of these assays as predictive biomarkers. In the previous videos, we talked about tissue-based molecular profiling, where the tissue samples are obtained, how they're processed, how a clinical diagnosis is made, and how there are other biomarker assays that are performed, both low-throughput assays, immunohistochemistry in fish, as well as next-generation sequencing from DNA that can be obtained from those samples. We talked about the 4 alterations that we're looking for on hundreds of genes simultaneously from next-generation sequencing of the tissue, and a number of examples commercially that are available. We talked about a number of different biopsy specimens that could lead to quantity insufficient, from fine needle aspirations to endoscopic biopsies to surgical laparoscopic biopsies of peritoneal disease to just diffuse type gastric cancer from any sample, and from ascites and pleural effusions, as well as exhausted blocks from original tissue biopsies. We talked about then the utility of liquid biopsy, looking at circulating tumor DNA to address that issue. And we talked about the basics of circulating tumor DNA. We talked about factors that affect the amount of circulating tumor DNA in the blood. And we looked at implications of therapy on the level of circulating tumor DNA. We looked at how different assays are developed for looking at circulating tumor DNA in both the stage 4 setting as well as the localized setting, looking at minimal residual disease. And we looked at the intentions of circulating tumor DNA in the stage 4 setting and contrasted them to circulating tumor DNA assessments in the locally advanced setting, both before and after surgery. We talked about the difference between a prognostic biomarker and a predictive biomarker and gave examples of those both from the tissue and from the blood from both the stage 4 setting and the perioperative setting. And in particular of interest is a predictive biomarker, because predictive biomarkers are dictating or directing on what therapy that we should or should not use in any given situation. Taking a step back, we look at the concept of precision medicine or personalized medicine then is acknowledging that gastroesophageal cancer as an entity has a lot of underlying genetic subgroups. And using the various molecular tests that we've been talking about, the idea is to help categorize patients into like groups molecularly that then could be matched to targeted therapies that are specific for that predictive biomarker. So we talked about heterogeneity of the disease from a perspective of anatomical location, from histological identity, whether it's a squamous cell cancer or an adenocarcinoma. We talked about differences in etiology, what causes each of the cancers. But now we're going to really be focusing on the molecular heterogeneity genetically and from a protein perspective. And so we did mention the Cancer Genome Atlas, the TCGA, that performed molecular profiling on hundreds of samples that were obtained from surgical specimens, so earlier stage disease, stage 1 to 3, and how they were able to categorize the cancers into subgroups, squamous cell being a completely different entity, but then even amongst the adenocarcinomas, 4 different clear entities: chromosomal unstable, Epstein-Barr virus positive, microsatellite instability high, and genomically stable. And something to note is that these are incidences below based on the location from the distal esophagus, the far end of the esophagus, to the far end of the stomach, and the proportion of each of those 4 subgroups by color code. It should be noted, though, that the incidences here again are reflective of early stage disease. And in fact, if you look at the incidences of these in a stage 4 setting, the MSI high and the EBV positive tumors are actually even lower in incidence. The MSI high tumors around 3% of stage 4 disease. So the vast majority are either chromosomal unstable, and a second would be genomically stable. The chromosomal unstable then are of significant interest because it's the most common one, but also because it is rich in predictive biomarkers. And that's shown here, where we have a number of patient samples. Each column would be a patient sample and tested for this panel of genes here. And you can see the abnormalities that are noted by color code: gene amplification, gene deletion, or point mutation. And first thing to note is that any given tumor has usually more than one genetic abnormality, even just looking at this few group of genes. If you were to open it up to hundreds of genes, you would see a number of different alterations. And so the next thing to note is that gene amplification, which is in red again, really clusters in this chromosomal instability subgroup. And we talked about gene amplification of receptor tyrosine kinases like HER2, which amounts to about 10 to 15% of all gastroesophageal cancer. And you can see it really does cluster in the chromosomal instability group. There are a few cases in the others, but the vast majority, as you can see, are here. You will also note that there are other receptor tyrosine kinase amplifications, and that together these can account for 30 to 40% of gastroesophageal adenocarcinoma. And each of these can be considered predictive biomarkers of benefit to matched targeted therapies. The last thing to note here on this slide is that there is not uncommon that there could be concurrent aberrations, like in these examples here, EGFR amplification and HER2 amplification. So this shows us that any given tumor may have more than one therapeutic option. So if we go back not that long ago, only 15 years ago, we thought of gastroesophageal cancer as one entity, and they were treated as such. However, over the last 15 years with molecular profiling, we can see and appreciate the immense interpatient heterogeneity from one patient to the next, having different genetic aberrations and molecular aberrations in their tumor. And so the relevance of this, of course, is that there are, of course, those tyrosine kinase amplifications that I mentioned, but others as well, and that each of these have potential therapeutic options, as these are predictive biomarkers. In green, you see the therapies that are already approved for gastroesophageal adenocarcinoma. You see one that is expected to be approved over the next months based on a phase 3 study that read out as positive. And then you see a lot of bolded therapies that are therapies available commercially and approved in other indications and other tumor types, but not in gastroesophageal cancer. And so that said, if a patient's profile had one of these aberrations, then we could attempt to obtain access to these therapies and work with insurance to do so. Or it could open up avenues of clinical trials that have these agents available in the trial. And then lastly, there are some agents that are only available in the setting of a clinical trial at the moment, but potentially in the future could be available. The other thing to note on this pie chart is that these are just gene sequencing results. It doesn't incorporate anything about protein expression levels. So you see here that there's nothing to do with PD-L1 expression or claudin expression. This is a gene translocation here. And so when we try and account for that, it adds another layer of complexity. And so in previous video, we talked about screening for overexpression of claudin and matching it to therapy with zolbetuximab. We talked about screening tumors for PD-L1 expression and their relative incidences based on different cutoffs of positivity, with intention to treat with anti-PD-1 or PD-L1 checkpoint inhibitors. And so when we add the underlying protein expression profiles to this complexity between patients by genetic information, it adds even more heterogeneity here, where there are certain biomarkers that I've highlighted that can only be assessed at the level of the protein. Some biomarkers, as we've been talking about, can be assessed both at the protein level or at the genetic level, and so there's redundancy there. And that said, some can only be done at the protein level, and we need to account for that. So the other thing that is misleading from pie charts like this is that On the surface, it looks that each patient neatly fits into each one of these categories. But as I pointed out, some patients' tumors could be positive in multiple biomarkers, and therefore these genetic and protein events are not necessarily mutually exclusive. As we've been discussing, we note that some patients' tumors, though, can be fitting into more than one therapeutic option. And on the flip side, some patients, despite all this profiling, may not have any predictive biomarker that's positive and therefore would not be eligible for any targeted therapy. And therefore, standard chemotherapy would be their best option. So, in addition to interpatient heterogeneity, we have to account for intratumoral heterogeneity and intrapatient heterogeneity. So, we alluded to this when we were talking about HER2 testing, where some cells may be staining positive for HER2 and other cells not. And we talked about how the more biopsies obtained from a given site, like an endoscopic biopsy, the better the sensitivity of finding HER2 and not missing it because of heterogeneity. So this was the first introduction to intratumoral heterogeneity and with respect to HER2. But that's not unique to HER2, and most biomarkers behave like this, in that, shown in this schema, that a cancer can be made up of multiple different subclones. Now, each of these subclones often have a similar background genetic profile, or what would be referred to as truncal events, events that are present in all the cancer cells because they happened early on in the development of the cancer. Examples of that in this cancer type would be TP53 mutation or other tumor suppressors like that, that was one of the first events that led to the development of the cancer. And so all the cells have that. However, then over time, different areas of the cancer evolve independently and can acquire different genetic events. And so if you were to biopsy one area, you could see one type of profile with certain genetic events. And then if you were to biopsy a different area, you would see a lot of similar genetic events, but also some events that are not present in the first biopsy and some events that are only present in the second biopsy. And so if we don't account for this or understand it, this could be problematic if we happen to biopsy a site that is not reflective of the full burden of cancer throughout the patient's body. In addition to that, even if you were to identify the most predominant clone in the cancer at baseline and target it appropriately, for example, if the light blue clones represent HER2 gene amplified tumors and you treat with anti-HER2 therapy, you may and usually do get a nice response. But over time, you may select for pre-existing resistant subclones, whether they were observed or not at baseline, and then this becomes the new predominant problem in the patient's cancer. This is referred to as temporal heterogeneity that leads to resistance over time of a given targeted therapy. So the way I view gastroesophageal cancer, which in my experience is one of the most heterogeneous cancers molecularly, is that you can see at baseline, a primary tumor can have multiple different clones molecularly. And at baseline, again, in the metastatic sites, could have different molecular clones, some of which seeded from the primary tumor. And so depending on where one biopsies, one may get a different picture of what the molecular alterations are in a given patient. And this is where we talked about circulating tumor DNA. One of its utilities is that it can assess from the blood and try and get a snapshot picture of all the different sites in one representative sample. And this is because we know that each of these sites would be releasing ctDNA into the blood. And so by getting one sample, you can get an assessment of each of these sites simultaneously. In addition to that, we talked about over time, as you get resistance to a given therapy and potentially new genetic clones, a repeat blood sample can then evaluate changes over time and maybe help direct therapy going forward. And so we saw this when we were comparing advantages and disadvantages of tissue-based versus circulating tumor DNA testing, in that ctDNA can represent all of the disease and therefore give us a sense of molecular heterogeneity in comparison to one biopsy site that represents only that site that was sampled. Now I'm going to show you a real example of this in a patient that had a primary tumor biopsy that was tested for HER2 that was negative for HER2. So there was no brown staining that the pathologist could see, and the FISH testing was also negative with a ratio of HER2 copies to CEP17 copies of less than 2, whereas a liver biopsy obtained also at baseline diagnosis was clearly HER2 positive with extreme high expression, as well as a really high HER2 CEP17 ratio. So there was clear discordance between the primary tumor and metastatic site. In this example of spatial heterogeneity, circulating tumor DNA identified HER2 gene amplification. And so this is an example of where ctDNA could spare patients from having to get a biopsy of a metastatic site to rule out this possibility. In this particular patient, after it was learned that there was HER2 amplification in the burden of disease in the blood and in the liver biopsy, anti-HER2 therapy with trastuzumab was added and changed the trajectory of outcome of the patient for the better. In addition to baseline heterogeneity, we can also see heterogeneity over time. And this is an example of that, where with serial blood draws, we could see evolutionary changes of the different genetic events. So this patient had HER2 gene amplification at baseline, was given anti-HER2 therapy, and had a response and cleared the HER2 gene amplification from the blood to non-detectable. But as a mechanism of resistance, when the patient had cancer growth, EGFR amplification was observed in the blood as a likely mechanism of resistance. And not shown here, the therapy was changed to anti-EGFR based therapy, and the patient had another response and clearance of that genetic aberration. So this is an example of heterogeneity over time, and using ctDNA rather than repeat biopsies to address that and to try and retarget our therapies. Now, at this point, we've shown you the immense interpatient heterogeneity, both at the genetic level, DNA, and at the proteomic level with immunohistochemistry. And we've also talked about an added layer of complexity with intrapatient heterogeneity, both at baseline within the primary tumor and from primary tumor to metastatic site, and certainly over time as mechanisms of resistance. And so trying to successfully group patients into molecular groups has been challenging. And in addition to all of these layers of complexity, we have to recognize that some of these molecular aberrations are relatively rare. And so trying to implement personalized precision medicine has been quite challenging to prove, especially in those smaller subgroups in this disease, which is really molecularly heterogeneous between and within patients. So the pursuit of successful implementation of personalized medicine along these lines of testing samples and grouping patients into like groups is challenging because of all of these things we've just discussed, both inter and intra-patient heterogeneity, and some biomarkers being relatively rare, and trying to study them in the classical way has been very prohibitive in the recent years. So now I'm going to introduce you to a study that we did called Pangea, which is personalized antibodies for gastroesophageal adenocarcinoma. And I'll take you through it to show the rationale on how we try to address each of these issues. So first, just to start, when we get to clinical trials, biostatistics, and talking about treatment therapy in each line of therapy, this will become more apparent. But just as a brief overview, the standard first-line therapy is, depending on the biomarker group, FOLFOX chemotherapy with, if you're HER2 positive tumor, it's trastuzumab. If it is a PD-L1 high tumor, MSI high tumor, it's nivolumab. And if it's negative for both of those biomarkers, it's currently just FOLFOX. And then if and when those first-line therapies stop working, which is referred to as treatment resistance, this is expected to occur. On average, happens after about 6 months. But some do better than that, some do worse than that. That's just the median time point, the halfway marker, where half of the patient's tumors have learned how to grow on the first therapy. Whenever it occurs, the treatment change is to standard second-line chemotherapy. And the standard biologic targeted therapy to use in all patients is ramucirumab. And then if and when that stops working, which on average occurs after around 4 or 5 months, then the standard is to change to third-line therapy and with chemotherapy and no real standard targeted therapy other than if it's a HER2 positive tumor to use trastuzumab deruxtecan. And then, so shuffling between all of the various therapies in tandem, ultimately we do run out of therapy options, and or patients are not able to continue on to later lines of therapy because of rapid progression of their cancer and deconditioning, so they're not well enough to receive the next line of therapy. So this study, Pangea, was conducted to try and improve our understanding of the heterogeneity of the cancer, to characterize what is the degree of spatial heterogeneity from primary tumor to metastatic site, and also what is the degree of evolution over time at each transition point between each line of therapy. And so classic clinical trials usually are only performed in a certain line of therapy, whereas the Pangea study was including patients from the beginning at newly diagnosed stage 4 disease, and then following them through 3 lines of predefined therapy based on biological characteristics of their tumor. So what was done was, at baseline, all primary tumors were biopsied and metastatic tumors were biopsied. This is not standard to go and seek a metastatic biopsy intentionally. Usually, as we talked about in the how do we diagnose and stage this cancer, the majority of cases are diagnosed with an endoscopic biopsy of the primary tumor, and then imaging with CAT scans and PET scans can help to define whether or not there's metastatic disease. And if there is, and it's obvious, then the standard of care is not to go and intentionally biopsy that metastatic site unless there's suspicion that it may be benign or it's not clear. So in some cases, you will have a metastatic biopsy, but the majority of cases do not. But in this study, it was indicated in the procedure to biopsy all metastatic sites. And the reason for that was because each tumor biopsy from the primary site and the metastatic site was molecularly profiled with next generation sequencing and a whole battery of protein assessments with immunohistochemistry and FISH. And then those results were run through a predefined treatment algorithm and assignment to pre-specify and address the problem that some tumors may have more than one targeted therapy option. And so in that setting, we had tiebreaker rules that would classify a patient into a certain group based on this algorithm that was a prioritization scheme. And so, for example, immunotherapy took precedence, but if there was not a marker for immunotherapy to predict benefit, then you would go to the gene amplifications. And if there was more than one gene amplification in a tumor, then the one with the highest copy number would take priority here, which is not a standard of care. But from our understanding, as I'll show you in a moment, the higher the gene copy number, the more likely the benefit. And so if you have 2 genes that are amplified, we would go after the one that has the higher gene amplification. And so this was conducted, and in every primary tumor was run through this algorithm, and every metastatic tumor from the same patient was run through the same algorithm. And if there was discordance between the treatment assignment between the primary tumor and the metastatic site, then the metastases was prioritized. And that rationale was the metastases are usually what are the problem going forward. And so we wanted to really optimize control of the metastatic disease. And so based on this treatment assignment at baseline that was accounting for spatial heterogeneity, patients were assigned a treatment group and the matched targeted therapy. You will note that the algorithm has an all negative group at the very bottom, which means that all patients enrolled were eligible for the study. So even if they didn't have an obvious biomarker to go after, then they were given anti-VEGF receptor 2 therapy with ramucirumab with the idea that they would still do better than they otherwise would without it. And so this was the first line therapy of chemotherapy with FOLFOX with the matched targeted therapy according to the metastatic site of that patient's biopsy. If and when there was progression of the cancer, growth of the cancer on this therapy, then patients would transition to second line therapy as they normally would, but a repeat biopsy of the progressing cancer, the cancer growing on the first line therapy, to try and identify why it's growing. And so that biopsy sample was then run through the same molecular testing and then run through the same treatment assignment algorithm and reassigned a targeted therapy. So if a patient's tumor evolved to a different molecular driver, then they would be assigned to a different targeted therapy along with the different second line chemotherapy backbone. On the other hand, if the tumor remained in the same molecular group after first line therapy, then they would change chemotherapy backbone, but they would stay on the same therapy, antibody therapy that they were on initially. And the same thing would be done at the third line setting. And so the novelty of this study is several fold, where first we were targeting the metastatic disease intentionally, and we were trying to keep up with the tumor, so to speak, through different lines of therapy to try and assess why the cancer might be growing and then readdress with targeted therapy accordingly. So this is the overall design of the study, and the primary endpoint of the study was to evaluate the overall survival of the patients treated with this Pangea strategy. And something notable was that because we had to obtain therapies for each of these specific biomarker groups, there were some groups that it was not possible to obtain collaboration with a pharmaceutical company to get access to those drugs. And so if that was the case for any group at any time point, the patient was treated with just the standard of care. They were still followed for outcomes, but they weren't included in a Pangea strategy treatment arm. They were just assessed independently to see how they would do without their matched targeted therapy. So what did we learn? The first thing that we learned from the biomarker perspective was the heterogeneity, which was expected, but we wanted to characterize what the degree of spatial and temporal heterogeneity actually was. So the top figure in A is showing you the baseline spatial heterogeneity from the primary tumor biopsy result to the metastatic tumor result. And so you see the incidence of each of the pre-assigned biomarker groups in each of the primary tumor and the metastatic tumor. And you can see that treatment changed based on the primary site versus the metastatic site in 35% of the patients enrolled. And so this is important because we could be targeting just the primary tumor, but it's not addressing the burden of disease in the metastatic sites. And so all of the biomarkers showed this discordance from primary tumor to metastatic tumor to some degree. And overall, as a whole, there was 35% treatment change based on the metastatic site. Importantly, all patients were getting a baseline circulating tumor DNA analysis with a Guardant 360 panel in that study. And the ctDNA was able to pick up the metastatic profile in 90% of the cases. So the importance of this is that ctDNA can adequately identify those metastatic sites and spare patients in the future from having to go and get a biopsy of their metastatic lesion, because a blood draw can, in most cases, account for that. The next thing we learned was that upon transition from first line to second line therapy, of the patients that had progression and changed to second line therapy and had the ability of getting a biopsy of their progressing lesion, about half of them changed their biomarker group compared to what they were assigned to in the first line setting. And so this is significant heterogeneity. And then similarly, from the transition to second line to third line, about half of the patients also transitioned. So what that means is that some patients stayed in the same biomarker group and they stayed on the same targeted therapy but changed chemo. But in those who transitioned to a different biomarker group, they not only changed the chemotherapy, but they also changed their targeted therapy. And so each of these rows represents a patient's trajectory, their course of care, that's color-coded by the biomarker that they were assigned to and therefore the treatment that they received. And everyone has their own story. As an example, this particular patient started out with an EGFR amplified tumor, so they were assigned to the EGFR group. They got FOLFOX chemotherapy plus an EGFR antibody. And when the cancer progressed, the repeat sample showed that it was FGFR2 amplified. The EGFR amplification had been suppressed. And so the patient transitioned to second line therapy with chemotherapy. FOLFIRI was the second line chemotherapy in that study. And then they received the addition of an anti-FGFR2 antibody. And then when that therapy stopped working, a repeat biopsy then revealed that neither her EGFR nor FGFR2 were the driving forces anymore. It was a different gene called KRAS, and therefore received an anti-VEGF receptor 2 antibody ramucirumab as dictated by the study. KRAS, as we'll talk about in later videos, is a very difficult gene to target. And so it was thought that the best option was anti-angiogenesis in patients that have that particular aberration. What you see below in this section is the trajectory of patients. Most of them were in the MET group and some in the FGFR2 group that did not have access to the matched targeted therapy. And so they were just followed over time. And of importance here was that you can see that the lengths of time that they were on each line of therapy were less. And that you can see that generally speaking, if they were assigned to a given group, they stayed in that group. And the thought there is that there was no targeted therapy to drive the cancer to resistance to select for other types of genetic clones because there was no targeted therapy on board. Whereas here you see this transition, this heterogeneity temporally, because we were putting pressure on the actual target to select for other cancer cells that didn't have that target. And so there we saw this heterogeneity in the Pangea treated group, but not so much in those treated with just the chemotherapy arms. The other thing, and the important thing, was that did this improve outcomes compared to what we would have expected as a historical control? And the answer is yes. You can see here that the median overall survival of those treated with the Pangea treatment strategy had a median survival of almost 16 months as compared to control arm, which would have been anticipated to be around 12 months. You can also see the patients that were treated in the non-intention to treat, the non-Pangea treatment arm, those patients that were treated with just the standard of care because they didn't have a matched targeted therapy available. And you can see their survival outcomes are significantly less. We also predefined that we would look at the different groups in the Pangea treatment strategy, stratified by those at the top of the prioritization scheme versus those at the bottom. And although the patients at the bottom, we were assigning them to therapy which we thought would be better than what they would have alternatively without the Pangea strategy, we expected that the patients at the lower end or the lower tiers wouldn't do as well as those at the higher tiers, which is the whole reason why we were assigning patients on this prioritization scheme. And so we did in fact see that the patients in the higher tier groups, those that were genetically driven by various receptor tyrosine kinase amplifications or had a high likely benefit of immunotherapy based on their biomarker profile, they did exceedingly well with a median survival of almost 26 months, more than twice of what would be expected as an outcome without these targeted therapies. And it should be noted, though, that even in the lower tier groups, they did better than would be expected as a historical control of around 11 or 12 months. And so in addition to that, we wanted to look at the HER2 group specifically because, of course, chemotherapy plus trastuzumab was already a standard when we ran this study. And the median survival there was around 14 to 15 months in phase 3 studies for first-line anti-HER2 therapy. But here, because we thought by addressing the spatial heterogeneity at baseline, patients who had primary tumor positive but metastatic sites negative for HER2, we reasoned that they would be better served with a targeted therapy of a biomarker that's present in their metastatic site. They weren't given anti-HER2 therapy per protocol. And likewise, patients who had a HER2 negative biopsy, but a HER2 positive metastatic biopsy, HER2 negative in the primary tumor and HER2 positive in the metastatic site, they did receive trastuzumab, and in the standard of care setting, they would not. And so in addition to that, we reasoned that at the time of each progression point, by reassessing the tumor biopsies of the growing cancer and reassigning therapy based on what's there and continuing anti-HER2 therapy in those that had persistent HER2 positive cancer versus changing to whatever biomarker was most appropriate if it was HER2 negative, we felt that all of those things would help to enhance the outcome even in HER2 positive group that already is getting trastuzumab in first line. And indeed, you can see here that the median overall survival was almost 26 months in this group, and pretty much double of what would be expected with standard chemotherapy plus trastuzumab in first line based on how it's conducted routinely in the first line setting. And again, you can see that in the non-HER2 group of patients treated per the Pangea strategy, they still did relatively well with a median survival of almost 15 months compared to, again, around 11 to 12 months as would be expected with just routine standard care. We also showed that the progression-free survival in first line, or the PFS in the first line, in the Pangea-treated patients was better than would be expected. Again, expected median is around 6 months, and so this was better in the first line setting. On the bottom figure, we see the overall response rate in the first line setting, which was 74%, and compared to historical control of what would be expected with first line therapy would be in the range of 40 to 45%, and the disease control rate of almost 100%. So the definition of overall response rate is a 30% or more shrinkage, and only one patient was defined as having growth as their best response to the first line therapy. So this rainbow waterfall plot is showing that almost every patient had tumor reduction in size, and about 3/4 of them had an official response as their best response to first-line therapy. So this is better than would be expected in the historical setting of just chemotherapy or chemotherapy plus trastuzumab for HER2-positive cancers. And you can see by color code of what the molecular assignment was of each of the patients. And by color coding, you can see their treatment assignment, and that each of the treatment groups contributed to this remarkable overall response rate. So that study, Pangea, was instructive to try and account for all the different hurdles, again, that we recognize now in this cancer type, which includes interpatient heterogeneity, everyone's different, intrapatient heterogeneity spatially from the primary tumor to the metastatic site. We learned that ctDNA can address that and account for all of that pretty well. The intrapatient heterogeneity over time, as you select for resistant clones, if you retarget your guns to the new problem, we can optimize outcomes. And so that said, this study, it was not definitive. It doesn't change any standard guidelines in terms of how to treat, but it does provide some understanding of the immense heterogeneity, firstly, and also strategies that we can adopt to try and address them going forward. And so that study, which initiated in 2014, becomes very relevant now today because, as we know, there are a number of biomarkers that are becoming standard to test for in the first line setting, HER2, and then immunotherapy biomarkers with MSI and with PD-L1, and having matched targeted therapies there. And I've been mentioning the Spotlight study with zolbetuximab for high claudin expressing tumors. And there are others as well that hopefully may become standard options in the near future. And so there will be a time that we need to prioritize a given patient sample, similar to how it was done in the Pangea strategy, because some tumors will have more than one biomarker, and we have to know which one to use for any given patient. And so what will be the best option? Of course, intuitively, everyone says, what about combining them? If a tumor is both PD-L1 high and claudin high, should we give both biomarkers plus chemotherapy? And of course, that's a very reasonable thought, but it takes time to do those studies, and that will be several years from now, in March of 2023. And so in the meantime, what will we do in this particular situation? And when we get to first-line therapy choices, we'll get into that a little bit more. But in addition to that, when you add other biomarkers that could be expressed, we'll have so many different subgroups of combinations of which biomarker is or isn't present. What will be the best treatment for any given individual will become very, very challenging to study. And so the incidences of each of these different subgroups here, what's the incidence of being PD-L1 positive and claudin positive, but HER2 negative, et cetera, are not really well defined or established yet. but one such study did show some of this recently. And again, similar to the previous plot that looked at molecular testing from the TCGA, you can see that each of these columns represents a tumor sample from a patient, and that each of the rows represents different genes from sequencing or different protein expression profiles, Claudin, PD-L1, et cetera, and other biological and clinical characteristics of the tumor, and also clustered by the TCGA subsets. And so from this, we're starting to observe what are the incidences or the coincidences of each of these biomarker groups. So for example, Claudin positivity seems to range between 25 and 30% across all the groups. It doesn't seem to be enriched much in any of the other subgroups. So it will be not uncommon to have a biopsy that shows high PD-L1 expression and Claudin high. Almost 50% of the Claudin high tumors were concurrently high PD-L1. And so this is the tip of the iceberg of having multiple biomarkers in a given sample, and how we're going to have to start prioritizing our treatments so that we give whatever is the best one to any given patient, even though they have more than one option. Very akin to the Pangea treatment algorithm. So we're going to pivot now, and I'm going to talk about molecular profiling assay performance. And what we're getting here is differentiating between all of this heterogeneity within a patient. So if you have one biopsy that shows HER2 positivity, but another biopsy of a metastatic site that shows HER2 negativity, this is one way that the assay may not perform well if you're not accounting for heterogeneity of actual true biological disease. But in addition to that, there's just the assay characteristics and reproducibility from one pathologist to the next, looking at the same slide, for example. And so immunohistochemistry, looking at various protein biomarkers, as well as FISH, looking at gene copy number, has interpathologist discrepancies well documented, and I'll show you some examples of that. There's some subjectivity in terms of reading the slides from the pathologist in terms of saying whether it ultimately it is positive for a given biomarker or not. Similarly, even next generation sequencing platforms, whether it's from the tissue or the blood, can be different from one assay to the next on the same sample. There may be different genes in the list of the panel. There may be different genes that are tested for each of the 4 types of the genomic alterations that we've been talking about: the point mutations, the gene copy number changes, the fusions, and the small insertions and deletions. And the different assays available may have different bioinformatic pipelines. This is through software that's used to look at the raw data of the sequencing and parsing through it to determine whether a gene is or isn't abnormal. And so different bioinformatic pipelines software may have different outcomes from the same raw data sequencing. So this is, again, in contrast to real differences between biopsies of a given patient because of heterogeneity that aren't because of the assay's performance, but just because of the true biological differences. And we've shown examples of the spatial heterogeneity as well as the temporal heterogeneity over time that truly changes after therapy. Now, the relevance of all of this is that in modern day, the biomarker that gets a lot of scrutiny is the PD-L1 test, and we'll go through that. But first, I'm going to show you that this is not new for PD-L1. HER2 testing went through this 20 years ago and continues to be a discussion even today, as I'll show you. So remember, we talked about how HER2 testing is performed. It is performed first with immunohistochemistry on the sample, and the sample is considered positive if 10% or more of the cells are staining at 3+ intensity of the brown staining on the slide. And it's considered negative if it is 1+ or no staining in 90% of cells or more. And in the setting of where it's equivocal, it's having 2+ staining. That's when FISH testing is performed as a reflex test, as a tiebreaker, to assess whether the ratio is higher than 2 if it's positive. And so we talked about the heterogeneity within a sample previously, and that we know that the number of biopsies from the sample, say, for example, a primary tumor biopsy with an endoscopic biopsy, we know that just one biopsy has a sensitivity of finding HER2 positivity, if it's truly there, of only 60%. Whereas if you increase the number of biopsies and assess all of them, often in the same block as I showed you, then you can increase your sensitivity. It's still not perfect, but it does improve somewhat. And so this is a known issue with HER2 testing and any biomarker testing in this disease. So there are many studies over the last while that have assessed the reliability of the HER2 score from pathologists. And a known issue is pathologists that are scoring this that are not well trained or that are not seeing a high volume of cases, they have a lower sensitivity and specificity of calling HER2. And they tend to be discordant from the results obtained from pathologists who are having a higher volume and are more heavily trained in scoring HER2. And local pathologists then versus centralized pathologists refer to those that are maybe not seeing as many cases as compared to those pathologists that are centralized, that are seeing them more frequently and potentially better trained. And we've known for some time that there's discrepancy, but this particular study, which was not that long ago, was a prospective study really assessing this. And that's why it's really an authoritative look at this. And what they showed was that in comparison from the local versus the central reading result, there was a discordance rate of almost 1 in 4 cases. And so you can also see that the majority of the cases were changing from a local score of being called positive for HER2 to a central score of being called HER2 negative. And so in other words, these patients are getting trastuzumab, but probably weren't going to drive much benefit because ultimately it was scored as being negative. There were some cases that were the reverse of that, where the central testing revealed positivity and the local test was actually being read as negative. And so these patients were treated per what the local pathologist had indicated, because this was an observational study. It wasn't to intervene and change the therapy. And so these patients did not get trastuzumab where otherwise they would have. And so the important thing to learn here is that the central read was what best predictive outcome. And so that's shown up here in the survival curves, where in green, it's where the pathologists were reading this as positive, as opposed to those patients in orange here that were being read as positive and locally HER2 negative. Remember, they weren't getting trastuzumab, and so they didn't do as well as HER2 positive patients that did get trastuzumab. And then finally, patients in red here who were called negative by the central pathologist, but locally were called HER2 positive and therefore given trastuzumab, you can see that they just derived no benefit. It was essentially HER2 negative, and the central read was better. And so when scored properly, HER2 testing does perform well. And this is an example of a biomarker of many biomarkers that just really needs to have the pathologist appropriately trained, and that you really want to go to a center that has a high volume of these cases so that you feel that you're getting the adequate read. The answer wasn't, well, just in case we should give everyone trastuzumab because some patients are not getting it that should be. Rather, the consensus here is that we should just have proper HER2 testing. And so other things that were learned from this study was that amongst the HER2 positive patients, even as scored by central testing, those patients that had higher percentage of cell staining seemed to do better than those that had lower percentage of cell staining. Remember, to be called HER2 positive, you need at least 10% of cell staining, but that means that 90% of cells aren't staining. And so what they showed was that increasing that threshold from 10% to 40% seems to improve the outcomes, and those patients that are below that don't seem to be deriving any benefit from anti-HER2 therapy. And similarly, they looked at the gene copy number by FISH amongst patients who were called HER2 positive, and those patients that had a high gene copy number seemed to do better than those that had a lower gene copy number, albeit all of these were above the standard ratio cutoff of 2. And so they showed that increasing that cutoff to a ratio of 3 seems to be better predictive of who might derive benefit from anti-HER2 therapy with trastuzumab. And so this is getting at the fact that any biomarker, whether it be HER2 or PD-L1, as I'll talk to you about, and even gene mutation scores, if it's positive or negative, it's a linear test and it's not binary. It's not obviously yes or no. We have to make a cutoff that tells us when it's positive or when it's negative. And you can see here that if you make the cutoff lower, that more patients are being called positive, but that they're not necessarily deriving much benefit. And so these types of studies that are looking to optimize what is the cutoff are really important. And this is not the first study to show that an optimal cutoff of HER2 is higher. Other studies have shown this as well. And this is an example of a FISH assay that shows a low HER2 gene amplification versus a high HER2 gene amplification. Both of these are technically positive above the ratio of 2. But we know in studies like this that the higher the gene copy number, the better predictive of benefit from anti-HER2 therapy in this case. And the reason for that is because when it's such a high copy number, remember, they have so much HER2 protein, they're addicted to this pathway. The cancer cells need HER2. And so that's an Achilles heel, and they're exquisitely sensitive to anti-HER2 therapy. Whereas those that are at lower levels tend to have heterogeneity of the sample. They tend to be more heterogeneous with cells that are and aren't HER2 positive. They'll show you in another study that looked at that. And also, they tend to have other concurrent genetic biomarkers that are also driving the cancer. And so they're not as dependent only on HER2. And so, as I was explaining, there are many other studies going back even 10 years ago where that showed the exact same thing, that the higher the HER2 copy number in orange here in each of these panels, the better the outcome compared to those that are lower HER2 copy number, but still above 2. So still HER2 positive by our current clinical ways of calling this HER2 positive, but they don't seem to derive much benefit. And this on the right was our study looking at protein expression, showing the same thing. The patients that had the highest levels of protein expression were the ones really that were deriving benefit. Those patients that were clinically HER2 positive but had relatively lower expression levels seemed to do just as well as those patients that were HER2 negative that didn't get trastuzumab therapy. So in addition to this understanding of biomarker assay performance and also looking at the level of the biomarker in terms of its positivity, we also see this intratumoral heterogeneity again that is real in terms of the differences. It's not the pathologist's subjectivity, it's just that there's different cells in the sample. And so this is an example that we had from a Pangea patient that was HER2 negative in about half of the cancer cells and HER2 positive in the other half. And then when stained with EGFR, a different receptor tyrosine kinase protein, you could see that it was exact mirror of that, where the HER2 negative cells were EGFR positive and the HER2 positive were EGFR negative. And so this is an example of more than one biomarker to potentially target, and which one should we target? And this was a particular example where the metastatic biopsy sites and the circulating tumor DNA all had EGFR amplification and not HER2 amplification or expression. And so this patient, per the Pangea treatment strategy, was given EGFR-based therapy. And that was directly different than what would be considered a standard therapy. Standard currently would be, well, it's HER2 positive in the tumor biopsy that we have, it's more than 10%, and so they're going to get anti-HER2 therapy. So this is an example of where intratumoral and intrapatient heterogeneity at a snapshot in time is important to consider. This is an example also of the reciprocal with respect to HER2, where in the previous example, it was HER2 positive in the primary tumor and HER2 negative in the metastatic site. This is an example of the exact opposite, where we have HER2 negativity in the primary tumor, but HER2 positivity in the metastatic site. So again, if we were just looking at the primary tumor, this patient would not receive trastuzumab, whereas in the metastatic site and the circulating tumor DNA was HER2 positive, and so this patient did get anti-HER2 therapy. And this is a study that was again looking at specifically HER2 heterogeneity over time. And what we saw was that patients that had biopsy before and after therapy, about 30% of them, after failure of anti-HER2 based first line therapy, were evolving to having HER2 negative tumors, whereas about 70% had persistent anti-HER2 positivity. And so this has implications on what therapies to choose in the next line, just like we did in the Pangea study, where these patients, it would make some sense to continue with some alternate version of therapy that has anti-HER2 therapy still in it, whereas this one doesn't make a lot of sense to keep having anti-HER2 therapy because it's no longer cancer that's driven by HER2. On the right here, they showed outcomes of patients who did receive anti-HER2 therapy in second line, which was TDM1 therapy. And the patients who derived any significant benefit seemed to be those who had persistent HER2 positivity, as opposed to those who had loss of HER2 positivity seemed to derive absolutely no benefit. In addition, what they showed in this study was that those tumors that were most likely to evolve to becoming HER2 negative were those that, to begin with, had a lower level of gene amplification. Those patients that tended to have persistent HER2 positivity tended to have higher gene amplification at baseline. And in fact, in our study, we looked, of course, at all biomarkers in that list of the prioritization scheme, but we can look at each biomarker individually. And for HER2, you can see that there was a proportion of patients that had cancer that was HER2 positive only in the metastatic site. And so traditionally, these patients would not get trastuzumab, whereas a larger proportion were positive in the primary tumor only and would have gotten trastuzumab standardly, but again, in this study, were not given anti-HER2 therapy because they had a better biomarker to go after that was in their metastatic site. And then similarly, conversion from HER2 positive to HER2 negative was in about half of the patients, as assessed from not only between first and second line, but anytime between starting first line to the end of third line therapy. And so you can see that there is a large proportion of patients that will have selection of cancer cells that are not HER2 positive anymore, which makes a lot of sense. And this is an example of one of a few that shows that the patient was assigned to anti-HER2 therapy to begin with, but then at the time of first progression, changing to second line therapy, the biopsy and ctDNA revealed KRAS mutation. And so this patient was not continued on anti-HER2 therapy per protocol. And similarly, from the transition to second line to third line, it maintained its HER2 negativity even after not getting anti-HER2 therapy in second line. So it's important then to understand not only the intratumoral and intrapatient heterogeneity, but we must also account for the assay's characteristics and reproducibility, where I just showed you with HER2, it's well known that there's discordance between local pathologist reads of HER2 and central pathologist reads. And so that said, again, the answer has not been, well, let's just give everyone anti-HER2 therapy because the biomarker is unreliable. Rather, the answer was, let's train our pathologists and let's make sure that we're getting our HER2 testing done appropriately with samples that have multiple biopsies to account for heterogeneity. Also, I would argue getting assessment of the overall spatial heterogeneity with circulating tumor DNA, and then also ensuring that we're getting this assessment at a center that understands these principles. So that leads then to PD-L1 testing, which is the modern day version of this the conversation, and I'll take you through that. So remember, we talked about how PD-L1 immunohistochemistry scoring is obtained. It is staining the tumor biopsy and looking for positive cells, not only in the tumor, but also in this case, lymphocytes and macrophages, because that has to do with the biology of how PD-L1 works and how it works as a brake on the immune system. And so again, on the right here are examples of completely negative versus very strongly positive and those that are in between. And remember also that this is a test that can only be done on the biopsy sample and can only be done with immunohistochemistry because the gene itself is normal. It's just upregulated in these cells. And again, this is a predictive biomarker benefit for anti-PD-1 or PD-L1 checkpoint inhibitors. And depending on what the cutoff is of score of 1, 5, or 10, the incidence, of course, changes. And the higher the cutoff, the lower the incidence. And so this is very akin to the HER2 cutoffs by ratio score, for example, by FISH. So a ratio of 2 versus 3 versus 4, the higher you make the cutoff, the less percent of patients will fit into that category, but the more predictive it is of outcome. So this is not unique, this issue that we've been discussing over the last few years of what's the optimal cutoff of PD-L1. It's just that we have to do the studies to identify which of these cutoffs is optimal. And so a few things that we should understand about PD-L1 testing is that there are a couple of different antibody assays out there, diagnostic assays. The two leading ones at the moment are an antibody called 22C3, which was coupled with the development of pembrolizumab or Keytruda. And there's also 28-8, which was coupled or developed with nivolumab, Opdivo. And so this is also not unique. HER2 has a number of different immunohistochemistry antibodies that are FDA approved and available, and also different FISH probe assays as well. So the multiplicity of PD-L1 tests available is also not unique. And so the first study, I don't show the data, but just to show you the paper that's listed here, looked at tens of thousands of samples, not all gastroesophageal, but certainly many of them were. They looked at all cancer types to look at the concordance rate of pathologists to be able to score PD-L1 by these two different antibodies. And their conclusion was that it is very concordant as long as the pathologists are appropriately trained. Another study looked at specifically for gastric cancer, again, comparing different antibodies, in this case, a third antibody that is often coupled with atezolizumab or Tecentriq in other tumor types, and looking at its concordance rate. And you could see that they were very well concordant. No matter what the CPS cutoffs were, you can see that their concordance rates were extremely high, almost 95% or higher. And also comparison of their performance between pathologists, 5 different pathologists scoring at the cutoff of 1 or 10 had extremely good overall agreement. In addition to that, another study compared again 22C3 and 28-8 in gastric cancer, and again showed really good concordance no matter what the cutoff was, whether it was 1, 10, or 50. In contrast, there are also studies that suggest that there is not great concordance. And when you read between the lines, though, what I take from all of these studies that have come out, of which there are a number in the last few years, is that when you look at the highest cutoff of 10 or higher, the concordance rate of positivity is very good. And the real discordance, if there's going to be any, is usually at lower cutoff levels. And my impression and my opinion is that, as we will talk about when we get to first line therapy and we talk about immunotherapy checkpoint inhibitors in first line, is that the patients that derive the most benefit, if not all of the benefit, are in the highest level group. And the ones who derive the least amount of benefit are in the low levels. And so in the end, the one that matters, that needs to be scored properly, seems to be really well concordant in terms of its reliability and performance characteristics. In addition to that, a very recent study that just came out, again, its overall conclusions was that PD-L1 testing is problematic and challenging and not really that reliable. Again, when you look at the details, is that on the left here, you see the scoring of positive or negative based on the CPS score of 1 as a cutoff versus 10 in the middle versus 20 on the right. And what you see is the different pathologist scores and the range in the red bracket. Again, the problem is at the lowest levels compared to those that are at high levels. And it's really the ones at the high levels that you don't want to miss. And so that when you're looking at the highest levels, you see that there's really good concordance. And then what you really should look at is that of the pathologists that were included in this study, a large proportion of them didn't get any training on how to score PD-L1 ever. And so, what I would argue is that we need to be having pathologists read these pathology slides that have actually been trained. And so a study specifically looking at that particular question was across various tumor types, including the ones of interest to us, gastroesophageal cancers, was that in this particular study, all the pathologists included in the study took a day-long online training course and then were given the slides to stain. And in that situation, you can see that there is great inter-observer agreement, even better than what would be considered good, as was seen in the HER2-based biomarker testing studies that were done like this. And so the conclusion really is that we should be training our pathologists so that they can be competent and perform these assays appropriately. And we should also finally note that in all of the phase 3 studies in gastroesophageal cancer looking at immune checkpoint inhibitors, and there are many of them now, there are many checkpoint inhibitor therapies, and there are many companion diagnostics that are matched with each of these different therapeutic drugs. And every study has consistently shown that the patients at the highest levels of PD-L1 are the ones that really derive the benefit, and the ones at low levels don't. And so from a central scoring perspective, because all of these studies had PD-L1 scoring done by central pathology testing of pathologists who had been appropriately trained, had seen high volumes of these cases, and were scoring it appropriately, it is very, very predictive. And so what we're now getting at is, what is the scalability of this assay? What is the reliability of this assay when it's given to all the local pathologists around that may not have that training, that may not be seeing as many patients? Well, very similar to surgeons. We're going to get to in the video on principles of surgery that it is well established that the surgeons who perform gastrectomies and esophagectomies more frequently are the ones that are more adept at the procedure, and that surgeons that are performing few of these in a year have worse outcomes. And so this is the same for pathologists. The pathologists who are more competent in scoring these assays, the better. And so again, the answer is not to say, well, let's give everyone an immunotherapy drug because we can't rely on this assay. Rather, it should be, let's train our pathologists appropriately, and then we will optimize the utility of this biomarker assay. Now, that's not to say, just like I showed you with HER2, there are the performance characteristics, and then there's the problem with heterogeneity that's real. It's not because the pathologist got it wrong. It's because the samples are different from one site to the other. That's true also for PD-L1. There is the reliability of the scoring and subjectivity of the scoring by the pathologist, but then there's also real differences from one biopsy to the other. And this was a study that we showed that was looking on the left two panels from the primary tumor to the metastatic tumor at baseline, two simultaneously obtained biopsy prior to any therapy, and looking at their concordance rates. And you can see a few things of importance here. First is, on the left here is the cutoff as 1, and on the right here is a cutoff of 10. And for both instances, there were situations that the primary tumor was negative and the metastatic site was positive. It wasn't common though, only about 10% of the patients. Whereas the reciprocal was actually very common, where the primary tumor was positive, but the metastatic site was negative. And so in this case, say for example, from the Pangea strategy, where we were treating based on metastatic sites, a lot of patients would not be getting anti-PD-L1 therapy or anti-PD-1 therapy, whereas they would have if they were just being treated by the primary tumor. And then on the right side, we were looking at heterogeneity over time, that temporal heterogeneity from the pre-treatment biopsy to the post-treatment biopsy, and the concordance rate of PD-L1 scoring. And in this case, again, we saw discordance between the pre-treatment biopsy being negative and the post-treatment biopsy being positive. So there was an evolution over time to positivity. Now, this wasn't as high as a percentage at the highest cutoff levels, but there was still a significant amount of patients that evolved to have higher PD-L1 positivity at the repeat biopsy. In contrast, the patients who had a positive tumor at pre-treatment and then evolved to becoming negative over time post-treatment was actually about more than a third of patients. And at the higher level cutoffs, a large proportion of patients that were positive pre-treatment became negative post-treatment. And so what we're getting at here is that with any biomarker, there's going to be subjectivity, there's going to be a threshold of what needs to be called positive and negative, And there's also going to be this added layer of complexity of heterogeneity, both at baseline at different sites in the body and also over time. And so the Pangea strategy, I think, should be instructive in that we should be assessing the tumor periodically, preferably at time points of when you're going to change therapy, reassessing what's going on in the tumor, and then treat accordingly. Again, I'm going to really highlight that despite all of these issues with PD-L1 as a biomarker, in every study that's been looked at that looks at PD-L1 CPS scoring, it's always very predictive when it's scored properly by central pathologists. And so our goal should be to ensure that pathologists are scoring this properly and that patients are being seen by centers that have understanding of this and that are evaluating this biomarker appropriately. So I've taken you through now the difference of understanding the assay's performance and characteristics and reproducibility. And I showed you examples of HER2 and PD-L1, but any biomarker can be scrutinized in this manner and will have discrepancies between pathologists that we are always trying to minimize with training. And there's also this problem of heterogeneity that's true biological differences spatially and temporally over time that need to be accounted for. So in this video, we've talked about heterogeneity of biomarkers, both the genetically at the DNA level and proteomically at the protein level between patients, but also the issue within a patient at baseline spatially and also over time, particularly after targeted therapies that select for different subclones, as well as biomarker assay performance and reliability, and the really important issue of pathologist training. And so this concludes then the principles of biomarker testing, where in the first part we talked about tissue-based testing, in the second part we talked about blood-based testing, and now in this third part talking about some of the concepts that we need to take into account, both molecular heterogeneity between and within patients, and also the biomarker assays, performance, reliability, and pathologist training. Thank you.